Hello. Uh, Today I'd like to talk about a new model for ACS based on JAMA cardiology paper by our group, along with circulation paper from our group that came out this month, uh, in addition to work from groups around the world integrating it. It um, the model is based on failed plaque healing secondary to inadequate intimal angiogenesis. As uh, we know, TCFAs can't really be considered vulnerable plaque if less than 20% ultimately result in ACS. And the focus here is going to be that mature angiogenesis is essential, not detrimental, for plaque stability. So, part one, acute coronary syndromes require a double hit of both plaque rupture and impaired healing. This is somewhat analogous to the situation in oncology, where after studying oncogenes for decades, it was discovered 50% of all cancers have a mutation in the p53 tumor suppressor gene. Failed healing is primarily due to loss of synthetic function and cellularity in vulnerable intima. We propose it is because of a lack of microvessels, lack of angiogenesis, reaching these vulnerable lesions, and were related at least in part to long cores. These microvessels, by maintaining intimal synthetic function, reduce both ruptures and they also contain thrombosis. And we're talking about mature angiogenesis, not immature angiogenesis. My name is Mark Brezinski. I introduced OCT imaging along with Jim Fujimoto in non-transparent tissue, particularly cardiology, in the 90s, along with a range of talented students and postdocs. I started the OCT programs at Harvard Medical School, MGH, and Brigham and Women's. Co-founded Light Lab Imaging with Eric Swanson and James Fujimoto. I won the Presidential Award for OCT in 1998, and I wrote cover to cover the textbook of OCT. Now, first of all, this presentation will include our group's work, but a substantial portion will integrate work from various groups producing pioneering work on plaque pathophysiology. Now, some of the PIs that have been part of our team, Maria Rupnik, an angiogenesis expert along with other expertise, been collaborating now approaching 30 years. James Fujimoto, again, my longtime collaborator in OCT, again over 30 years. Frank Willard has been important on what's being presented, an anatomist at the University of New England. Kishore Hajar did some of the early work. He's at Geisinger. And these are some of the institutions I grayed out Mass General because they were important earlier in the story, not in this later, not in the later half of the story. And so, first, discuss the TCFAs are not vulnerable plaque. It's important to go over the time course of clot formation. It's not the clots, when there's a rupture, clots don't occlude vessels instantaneously or over short periods. And that's critical in understanding how healing is important. The relationship between long cores and healing, which is also relation to the relationship between angiogenesis and healing. And here we're not dealing with systemic healing mechanisms. We're dealing with tissue or plaque healing mechanisms. And we will also, again, be presenting a lot of work from other groups. So the two papers from our group, this one from Cardiology earlier in the year, and this one from December December in circulation are sort of the core of what the talk is about. So the plaque rupture concept came to the forefront with this paper led by Jim Muller in the New England Journal of Medicine in the mid-1980s, though plaque rupture had been around since as early as Virchow in the 1800s, but this is what propelled the field. But it's a complex issue because of the incidence of ACS related to plaque rupture, the incidence being less than 20%. And so in this plaque I liked for the point of this discussion. It's from a previous papers of ours where we looked at polarization sensitive OCT for assessing collagen in coronary arteries. But this plaque has an atheroma, a more calcified, more solid core, and then a fibroatheroma all in one cross section. But the key point is on the right, we stain the tissue with picroceras, which identifies organized collagen type 1, is particularly bright. But the arrow shows at the corner of the TCFA that it's depleted in collagen, and it's also depleted, it's shown in the original paper, not here, in cellularity. So on rupture, this has no mechanism for healing or getting cells into the clot to contain the clot. What's also critical, which we're going to come back to, is we don't know the axial extent of this TCFA. How long is it? It could be 500 microns. It could be 20 millimeters. So again, the question that's been plaguing the field is less than 20% of TCFAs progress to ACS. So TCFAs aren't really vulnerable plaques. They're the origin of atherosclerosis. And this was recognized by Mann and Davies, who described in 1999 how subclinical episodes of plaque rupture occur and then form stable plaques, a lot of which end up getting stented. And Peter Stone, right around the time of the Prospect study release, also published this paper, and paraphrasing this group, also Gary Mintz, we need to identify what's vulnerability in a plaque, what predicts death, myocardial infarction, or progressive angina, 20% or less. And we don't have hard numbers on that less than 20%, how much less than 20% it actually is. And one of the keys is going to restricting clot formation after rupture. This seems to be the key question, because if over 80% at least are not not going on to ACS, the clot is being contained. So how? And we're going to look at the relationship with long cores. So after rupture, immediate occlusion is not the time course. If this was the case, healing would be less important here. Once the plaque ruptures, it can be days to weeks before an occlusive event occurs. And this paper from Circulation in 2005, I'm going to quote their conclusions. And at least 50% of the patients with an acute STEMI coronary thrombi were days to weeks old. This indicates that sudden coronary occlusion is often preceded by a variable period of plaque instability and thrombus formation initiated days or weeks before onset of symptoms. And this is just for STEMIs. When you consider the plaques that stabilize, how long does this process go on for? And this Geary study from 1998 was an animal study, but it couldn't be done in humans. And they saw that uh, within 2 to 7 days, you started to see healing. Endothelial cells and smooth muscle cells, there's a little bit of controversy if they're actin negative, meaning they're non-contractile, or actin positive, but they have the phenotype of smooth muscle cells. These smooth muscle cells are synthetic. They produce collagen and the supportive tissue in the area to stabilize a clot and to stabilize the plaque itself. And Falk recognized the dynamics of uh, this clot formation back in 1985. He was one of the people who did. And this from Kramer and Romani is another paper that talks about this relationship of thrombus healing and sudden death from 2010. Uh, so vascular smooth muscle, which are synthetic, are very important. Their phenotypes, where they come from, I'm not going to get into here. We're going to go under the assumption that they're coming from predominantly the plaque and not coming from the blood. And same thing with the endothelial cells. I left a reference, but I'm not going to talk about endothelial cells in this presentation. Now, the second study here supports this concept of healing, which I'll discuss in a minute. The only issue with this study, or an issue with this study, is that it's an in vivo OCT study where the verification of OCT of what healed plaque looks like with histopathology was based on only one paper, the top paper. So that's a little bit problematic. But just assuming that the validation is correct, then in the second paper in March of 2019 in JAMA Cardiology, they found in patients who had multiple ACS episodes, they had very few healed plaques in their coronary tree, whereas patients with more stable plaques, with stable plaques, or only a single episode of ACS, had a lot of healed plaques. It showed an in vivo relationship by between healing and instability, actually an inverse relationship between healing and instability done by OCT. So how do long course relate to failed healing? Again, we don't use the best histology for these YouTube videos because of copyright issues. We save those for papers, but here it's a cross section of a fibroatheroma. The cap here is on the thicker side at best. The thinnest portion is 200 microns, so technically it's not a TCFA, but that's not the point. We and other groups had looked for decades at collagen in the wall and differences in the lipid composition and shape, and trying to figure out what, based on cross section, was the difference between those 20% that led to ACS. And I was asked to read films in Geisinger, and this was a fortuitous situation because we ended up looking at the axial extent of plaques much more seriously based on a case, which I'll present in a minute. Geisinger Hospital in Pennsylvania. Now, it wasn't that we hadn't seen the long cores actually. This is what an OCT system looked like in the 1990s. And I remember when talking to Gary Turney when he was a student, that we were looking at these long necrotic cores, and I was commenting on how artistic they were, and it took like 15 years to figure out they actually were a danger. So uh, the um, the initial case, um, and then we went back and looked at a lot of our OCT images and histopathology that saw more evidence of this. But in this particular case, a patient underwent a stent placement. But during the stent placement, they had had two TCFAs, and one was proximal and one was distal. And during the stent placement, the proximal one, which was not the culprit lesion, was ruptured, and it was in proximity to a long necrotic core. And in spite of being on triple antiplatelets and anticoagulation, the patient occluded the vessel. And this is discussed in the paper. Now, the second TCFA, which was more distal, also ruptured during the whole process, but it was not associated with a long necrotic core. The necrotic core was minimal, and so no clot formed in the second TCFA. So the fact that one TCFA without a core didn't form a clot and the other one with a massive core did goes again for this is tissue related or plaque related properties rather than systemic healing. And since then, there's been a few studies that have supported, first of all, going back, I used the term shaft to describe these long cores in the Geisinger, in the paper with Geisinger, because it didn't come to me looking at the films. It came to me when I was passing over the where the Knox mine disaster occurred, where the river got too close to a or a mine shaft got too close to the river, broke through and flooded and killed miners. And the analogy uh, led me to think down the lines that this is a potential etiology for ACS. But getting back to the slide, since 2014, multiple papers have been published which support this concept that long axial cores are increased the risk of ACS. And we're looking at two papers here. And I just want to show OCT images and growths of this. If we look at the bottom, this is a 40 millimeter core. It extends from the LAD down, or excuse me, from the left main down the LAD, and it crosses over. And this is something we had noticed in the 1990s. They don't stay in one plane, which is going to represent a diagnostic problem. And we see this in the cross sections in A, B, and C. It's obviously thin in A, but it's crossing over, so it's not staying in one line. And as you know, OCT systems are designed to look longitudinally in one axial plane. But we did manage in D to capture a long extent of it, and shows that this is just, and we can see it from the growth, this is a massive amount of necrotic burden, but it also poses a lot of other problems. This is a long core. And so we began looking back at the literature and went all the way back to the 1930s, including papers by, for instance, Patterson. And there was only one paper that really looked at plaques longitudinally, and they were looking at a different issue. It was done by, among others, Muller, Romani, and Stone. But they were looking for the frequency and distribution of fibroatheromas and ruptured plaque. They did a huge number of plaques. It's a great study to some degree. We followed their protocol, but each section, they cut off the edges of the segment. And so it was hard to discern plaque core, true plaque core length, and plaque or core surface area from their data, but that wasn't really what they were looking at. But it was just astonishing. Nobody had really looked at this. So why would a long core potentially be a problem? Well, first, there's a higher statistical probability that it's going to thin out and rupture along its length. There's a lot more core to evacuate. There's a reasonable probability the core composition is different than smaller cores. But there's a reason why there's a reduced tissue healing capacity. And this occurs both with respect to TCFAs, which can become thicker, some studies have shown, and become thick cap fibroatheromas, or after a rupture, healing to contain the thrombus. And that's shown in the drawing, and it's also shown in the drawing how the cores don't stay in a single axial plane. So angiogenesis. Angiogenesis, since the 1980s, has been considered bad in plaque. Yeah, it does contribute cholesterol, but it also is, a lot of people assume it causes rapid plaque expansion, but really that's only an issue for animals and conduit vessels like the carotids. Now again, we don't, our best histology is in the paper, so I would suggest going back to the circulation paper to look at the histopathology there. But in this particular image, we're looking at a long necrotic core, 10 millimeters. Its composition is varying, and clearly in the regions marked NC, the degradation is much more severe. But there's a second thinning area where there's the red arrow, and it's in the insert in B. This is a TCFA with a minimal core, which is not likely to run into a lot of problems. On the other hand, when we look at C, the necrotic, as we look at the necrotic core on the left, and there is another necrotic core close to it that may be contiguous in another plane, but irrespective of it, the angiogenic vessels predominantly come up above, from the left, above the necrotic core, and they end. And so the arrow with the area with the green arrows, there's no blood vessels or minimal blood vessels and minimal cellularity, and the core is coming close to the surface here. So this is an area at risk for erosion, rupture, and poor healing. We do see blood vessels coming up between the two necrotic cores trying to come up, but that's not the predominant mechanism. So I got used this relatively recent review on angiogenesis and atherosclerotic plaque to look at the state of thinking. It's 2017, but it's been a widely held belief that angiogenesis is bad, and this was also seen in pretty prominent 2003 New England Journal of Medicine paper, and I have had a long time collaboration with Chip Gold, who's now deceased, but they did talk about the role of cholesterol, but also enlargement of the necrotic core was discussed in this paper, which we really don't feel is a major issue with angiogenesis, and we're going to hopefully support that point. This is another Romani et al. Paper, Colucci, and their talented group, and they do talk about the fact that the angiogenesis is predominantly in these plaques is incomplete. These are immature vessels. So they do leak and they do produce cholesterol from the red blood cell membranes into the plaque. But we're going to talk about it later. One of the goals is to produce mature vessels and extend the vessels and not to inhibit the vessel formation. So, several lines of evidence. First of all, we started looking at long cores, and after the 2014 paper, actually the case was in 2013, and we started to see that angiogenesis was not um, tracking the full length over the necrotic cores, and it was not reaching areas that were becoming acellular. We started to look back then at prior work, and the Berger-Silverman group, though they were trying to get across a different point, seems to be the origin of some misconceptions. One is rapid plaque expansion, but also that if you look at drawings in recent papers of angiogenesis um, uh, in atherosclerotic plaque, it's drawn as centripetal. And when we look back at their data, and when we look at our data, that's not the case. It's not centripetal, and we're going to go into that in a second. And in their work, they injected um, a resin, and which got into the angiogenic vessels and then dissolved the plaque. And under 3 here, we don't have to dissolve the plaque. We can inject now, since we have OCT, contrast media and then image through the vessels to see the contrast media without actually needing to dissolve them. And uh, we want to look at the data on angiogenesis inhibitors and thrombosis in patients who are on angiogenesis inhibitors. So again, you're not going to get the best of our histopathology in these YouTube videos. I would suggest going back to our papers, include particularly the circulation paper. But here we're staining a long core with von Willebrand's factor. The top is trichrome, the second B is von Willebrand staining. This is a coronary artery where the microvessels, the angiogenesis appears to be coming from the branch vessel and the region of the branch vessel on the right. And then it does what we've seen in many plaques. It rides above the core, which we have marked as CR here. And so the arrows, black on A, white on B, are showing the vessels near the luminal surface tracking along the length, but they're not coming up through the vessel wall. What's also interesting, and we've seen this time and time again, at the edge of the core, we see a lot of adventitia and a lot of vasa fissorum, and we don't see it in the center of the cores. Now, it can be said in small samples this is due to histologic processing, but we see it at each end of the core, but not over the core. So further work is going to need to be done on it. But if we go to D, the red is microvessels, or you can see it in C. The vessels are going above the core CR, but they're not coming up through the core, and they're not going underneath the core. And on the bottom, which is again in the circulation paper, we used much more of this. Since the von Willebrand's factor stained red, we took the red channel and converted it to grayscale. So white is, the white streaks are endothelium. And this comes from the area where the leftmost arrows are shown in A and B. And so the microvessels are near the surface, but they are not coming up through the media predominantly. So we discuss in the circulation paper a lot the three papers from the Berger group. And in particular, we're focused on the second paper and the third paper, particularly figure 1 and table 1 of that second paper. And figure 1 in the third paper. And figure 1 in the third paper is the only paper we felt we could clearly get images of the could clearly see from the images what the pattern was in the angiogenesis. And they had done the injections with cinematography, but we were unable to get the actual videos. It's unclear. We've contacted one, Berger, I believe, is no longer with us, but we contacted one of the other investigators who does not believe the films exist anymore, but we did the best we could from the still images. But table 1 was the most useful for our analysis, and table 1 contained each individual vessel used in their studies, and they had looked at the concentration of microvessels in the adventitia, media, and intima. And so when you looked at their data, the average adventitial vessel concentration and the average intimal vessel concentration were very close. But when you analyzed the individual data, fortunately they put each case in a table. In the coronaries with plaque, there wasn't a correlation between the adventitia and the intima, nor between the media and the intima. So on the left, and this is described in detail in the circulation paper, but highly statistically significant difference between the number of vessels in the media versus the vessels in the intima. And the vessels were not predominantly coming through a centripetal approach. They were coming up, and again in the third paper, figure 1, you see this pretty clearly. They came up and then they would run along the course of the lumen. In fairness to them, they were just trying to demonstrate the vessel's angiogenesis occurred from the adventitia, though they did comment on plaque expansion and its role in coronary occlusion. But a lot of misconception was drawn from their results. Again, though, the top of the figure in the upper right, the correlation plot. This is actually intima versus media, and there was no statistically significant correlation between intima and media, and you saw the same thing between intima and adventitia on the bottom. There was no correlation between the two when plotted individually or when you paired the actual data. So that was explained in the paper, if my explanation now wasn't very clear. So after rupture, clots may take days or longer to form. And so to contain ACS, you need to get smooth muscle and microvasculature in there. The microvasculature, though, is coming over, in the case of necrotic cores, over the top of the necrotic cores. And if you've got long necrotic cores, it's not reaching areas. And we've seen it, we've presented the data, but we've seen it in slides after slides. It just doesn't make it over long course. So long course provide a risk just on the basis of difficulty in getting vessels there. And we discussed tissue factors versus systemic factors. Besides our paper, I just listed 2 other papers where they demonstrate in vivo. You go in and look at the culprit lesion, but you have other ruptures where there's no clot associated with it. Just a moment on angiotensin inhibitors in vivo and thrombosis. And so it's been looked at now pretty extensively, and here's two example papers, but in particular certain angiogenesis inhibitors are associated with an increase, not a decrease, in myocardial ischemia and arterial thrombosis. And so this further supports this concept that angiogenesis is essential. What does this mean for diagnostics? Well, we had spent over a decade trying to demonstrate that OCT doesn't really measure macrophages, and it may be a moot point. What we really need to be looking at is areas that are devoid of vasculature, devoid of collagen. And so I'm not a big fan of OCT Doppler. It's one of the only two chapters I didn't write in my textbook of OCT. But we showed you our work on polarization sensitive OCT for collagen, but also elastography. And I did an extensive review. Unfortunately, I didn't cite it here. I'll cite it in the header of the YouTube video. But why IVUS, the pressure associated with IVUS ultrasound wave, makes IVUS not useful for doing elastography, and pulsed ultrasound with OCT is unlikely to be successful for elastography. But these are some of the diagnostic approaches that may be needed to identify vulnerability along with length of core. With regard to treatment, we may need to start looking at other treatments. How do we make angiogenic vessels more mature and extend farther? How do we make smooth muscles more robust? That's what's going on in the osteoarthritis world. They're trying to make chondrocytes more robust, increase their synthetic capability. And that may be a strategy that needs to be taken with future medications for ACS. And I'd like to thank our funding groups, the NIH in particular. We've also, particularly through Frank Willard, had a grant from the University of New England. Thank you.